Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is mental health as the new fall risk, the importance of a proactive strategy to manage the legal risks associated with the increasing rate of mental illness. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Dr. Sara Hamm and Ms. Kimi Gordy. Dr. Hamm is an accomplished nurse executive with more than 3 decades of service in senior living and post-acute care. Sara currently serves as the Senior Vice President of Successful Aging and Health Services for Lifespace Communities. Sara is responsible for providing strategic vision and executive leadership for all health and wellness services in the health centers, assisted living, memory care, and home health programs at Lifespace. Sara graduated with honors from Marquette University, with a Bachelor of Science in Nursing degree, and also holds a Master's of Science degree in Educational Psychology and Community Counseling from the University of Wisconsin. She completed her Doctor of Nursing practice degree in Executive Leadership at Loyola University in May of 2018, where she received the School of Nursing 2018 Scholar Award. Sara is a licensed nursing home administrator, a certified dementia practitioner, and a certified Alzheimer's disease and dementia care trainer. She resides in Boca Raton, Florida, and Milwaukee, Wisconsin, with her husband Brian and 2 golden retrievers, who are both certified canine assistant therapy dogs. Kimberly Gordy is an associate attorney with the law firm BakerHostetler, LLP. Her practice focuses on the healthcare industry with an emphasis on healthcare privacy and data security, breach response, and HIPAA compliance. Ms. Gordy has specialized knowledge in the unique challenges and risk management issues facing long-term care providers and has provided privacy and regulatory counseling to a variety of clients in the long-term care industry. Her background grants her insights into the latest advancements in information technology, a nuanced understanding of privacy law, and a comprehensive understanding of healthcare operations. A trained clinical ethicist, as well as a lawyer, Kimberly enjoys working with clients to navigate the intersection between legal risk mitigation and everyday healthcare operations. She has extensive experience in government and internal investigations and regularly advises clients on fraud and abuse issues and employment-related healthcare matters. Her work on patient consent is published in the Yale Journal of Health Policy, Law, and Ethics, and she is a frequent speaker on issues related to privacy, long-term care, and employee training. And now, please help me welcome Sara and Kimi.
Thank you, Robin.
Thank you so much, Robin. We're so excited to be here with you today, and we're talking about what I know both Sara and I feel is an incredibly important topic. Sara, with her clinical expertise, has seen firsthand how important mental health is for residents. And then from the legal side, I've seen the costs to a community that not taking care of resident mental health can have on employee turnover, on a regulatory analysis, and just on your overall sense of well-being. So I'm going to turn it over to Sara to get us started, and hopefully you'll enjoy the presentation.
Thank you, Kimi. And as Kimi said, we're really thrilled to be with the audience today. Sadly, in 2019, this topic is still a bit of a taboo topic, similar to 2 other topics that Kimi and I often present to groups across the United States, being sexuality and the aging process, as well as advance directives, which are also very, very hot topics for senior living and long-term care. But this is a critically important topic that we need to discuss very transparently, and we need to work together to ensure that all of our team members in senior living and long-term care receive adequate training and education to provide high-quality care to individuals who are impacted with mental health and mental illness. We could truly spend an entire day on each of the topics that we're going to be going through with you today, but we tried to pick topics that we felt would be of most interest to you. And certainly if you would like any subsequent webinars with more detail on something like lateral violence and bullying, which we will be discussing today, we would certainly be happy to work with Direct Supply to do that. The first thing I want to discuss is, why are we not addressing mental health challenges among aging adults? And truly there's a plethora of reasons. But first and foremost, we have so many residents who just refuse to seek help. They are from a different generation. Many of them grew up with families where you didn't talk about issues with depression or schizophrenia or other mental health or psychiatric illnesses because it was, quote, a sign of weakness. So there may be an intent, an ingrained emotional fear of coming forward to discuss any mental health issues that the resident may be experiencing. Certainly something that all of us are experiencing across the United States is a profound shortage of geriatricians and geriatric psychiatrists and mental health professionals, and particularly for those of you who live in smaller rural communities. When you have a psychiatric crisis in your health center, your assisted living community, or even in independent living, it is often very, very difficult to link residents with high-quality services. And I don't know how many times over my career as a registered nurse we had a resident or patient who was truly experiencing a psychiatric crisis to the point that they became an imminent danger to self and others. We facilitated a transfer to the local emergency room, and 20 minutes later they were sending them back in the ambulance with absolutely no intervention whatsoever. And sadly, I know that still happens today. Also, I think many providers still have a fear of litigation and regulatory backlash. What is going to happen to us if we have a very, very serious incident and accident between two combative residents? Many of you probably have Alzheimer's and dementia special care programs on your campuses, and we can see some very aggressive and violent behaviors between individuals who have cognitive deficits or other mental health issues. So that is often a fear on the provider side. The other thing that I have sadly seen over the years is what we call the clinical denial decisions, or a more derogatory term would be the clinical dumping of these residents. You know, you have one very, very bad behavioral health incident in a health center, and the team member's immediate response is to call the police and put them into an ambulance, send them to the hospital, and call the hospital and say, we are not going to take that resident back again. We can't handle the resident. And that is very, very sad, because when these individuals do receive the appropriate care and intervention, when they are stabilized on medications, they can have a very, very quality existence within your health centers and your continuing care retirement campuses. So we should never give up on a resident simply because they have one serious behavioral health incident. Also, something we need to talk about, there has been a real lack of reimbursement and focus on short-term rehabilitation stays. In most skilled nursing and rehabilitation health centers, that is the bread and butter. And if you look at the Medicare per diem rate you are getting for a short-term rehab resident who needs a lot of OT, PT, and speech and a lot of skilled nursing care, those reimbursement levels are significantly higher than what we get for an individual who has profound depression or schizophrenia. So sadly, that is also entering into the picture. And last but not least, inadequately trained team members in post-acute care and senior living. So that continues to be a real problem. So how do we go about recognizing and responding to mental health issues? And we're going to talk about some of the top common challenges that your teams are probably dealing with on a daily basis. Certainly, depression is very, very prevalent in aging adults. as is relocation stress syndrome, which is transfer trauma. And with the focus on preventing avoidable hospital readmissions, we're going to talk a little bit more about relocation stress syndrome or transfer trauma today. Also, the rate of suicide among aging adults is one of the highest of any age group, and particularly for Caucasian aging men. So we are going to have a discussion on suicide. Bullying. We have residents who live in our communities who are really pretty serious bullies who can create a very unhealthy and unsafe environment, not only for your residents, but certainly for your team members. So Kimi is going to lead a discussion on lateral violence and bullying, which is a topic I've done quite a bit of research and I've written publications on. And last but not least, the sad incidence of substance abuse, misuse, and abuse, whether that is drugs or alcohol. Everyone with us today knows that the United States is experiencing a horrific opioid crisis. And in each of our communities, we are losing young adults, middle-aged adults, but we are also losing aging adults on a daily basis to this terrible opioid crisis. So depression presents very, very differently in aging adults. And as we are heading into the new Medicare patient-driven payment model, PDPM, and the new MDS process, it is going to be critical that your interdisciplinary teams are working together to really identify residents who have symptoms of depression. But it is important for you to know that sadness and a depressed mood are not necessarily common symptoms of depression. What we often see is anhedonia, which is just a basic lack of pleasure or enjoyment in activities and the types of things that the resident really, really likes to do. If someone absolutely loved playing bridge every Tuesday and Thursday afternoon, and they're now self-isolating in their apartments, those are the types of behaviors that may be more indicative that we have depression going on. Residents suffering from depression often exhibit very subtle symptoms. In many instances, they show a lack in self-care. Perhaps Mrs. Smith always came down to the dining room very, very well dressed, with her hair perfectly done, her matching jewelry, and suddenly she's coming into the dining room in a robe and slippers and no makeup, just doesn't care how she looks. Answering "I don't know" to simple questions, and not because they're impaired, they just don't have the energy and they don't want to engage in a conversation. So you may get very, very short, non-meaningful responses to questions when you are trying to engage them in a conversation. And also, residents may complain and make statements like, "Nobody needs me anymore. You know, all of my children are gone. Nobody loves me. I'm just too old, and I go where I'm told to go, or I'll just be in everyone's way." And I'm going to give you a recent example of something that I'm currently going through with an aging parent. And let me tell you, after being a clinician and someone who has worked in senior living and long-term care my entire life, I am now the adult child of an 87-year-old mother who is starting to really fail. And my mother is a very, very active, independent woman. She is living in a senior living community here in Wisconsin in an independent apartment. But she recently lost her dog of 16 years, whom she loved like one of her children. She is going blind from macular degeneration and recently had a pretty horrific car accident where she finally had to give up her car keys. Her car was completely demolished. She was no longer able to be insured. So we've had 3 pretty critical events in the last year. and she has really become very, very depressed. And I was with her last week, and she was basically telling me, I don't care. I'm going to go to the Toyota dealership and I'm going to buy another car. I need to have wheels. I cannot live without being able to drive. And I had a very frank conversation with her as to why that was not a good idea, not only in endangering her own safety, but the safety of everyone else on the road. And she looked at me with her big green eyes and she said, Sara, then I might as well just kill myself because I can't live this way. I don't want to live this way. And my mother has never had issues with depression, but this is an example of some of these life events that our residents go through that can really pile up very, very quickly that we need to be alert for. And certainly if we have verbalization, such as what my mother shared with me, well then I might as well just be dead. I don't want to live this way. One of the other things I just wanted to mention briefly to you today, for those of you who are particularly working in skilled nursing and rehabilitation, is the new requirement that will be going into effect by CMS in November, and that is trauma-informed care. And this is a brief definition of trauma-informed care, but it's a very holistic, person-centered approach to treatment that understands and incorporates not only the biological, but the physiological, neurological, and social impacts of trauma on an individual. And if you think about the rich histories and the lives of the residents that we are caring for on a daily basis, they have had some absolutely wonderful, glorious, beautiful experiences, but many of them have also suffered significant trauma. We have many residents living on my campuses who lost many, many family members in the Holocaust. We surely have many individuals who were prisoners of war, or they were tortured as prisoners of war. And we certainly have individuals who have endured years of physical or mental abuse, and perhaps even sexual violence and severe traumatic injuries. And I'm sure everyone on the call today can think of a resident whom you've cared for over the past years that has had very significant trauma in his or her life. And it is very important that our interdisciplinary teams, when you are doing your evaluations and assessments, that you really work to identify some of those past traumatic experiences so that we can do a better job of planning care and providing care to these individuals. And I like to think about the 3 E's. What were the events and the experiences that that individual endured over his or her life? And what were the effects of those experiences that we need to be fully aware of in order to provide trauma-informed care? So trauma survivors, according to the new CMS regulation, must receive culturally competent trauma-informed care in accordance with professional standards. So if someone really has post-traumatic stress syndrome and they are still suffering the effects of perhaps AEDs and bombings that they went through, if they were severely physically abused and they need their personal space and do not like to be touched by individuals or hugged by your team members, those are the things we need to be aware of so that we're not triggering those past memories and responses. So again, that's what the second bullet point is really referring to. This new rule and regulation will be implemented in the Phase 3 requirements that go into effect on November 28th. And thorough assessment and interdisciplinary care planning is really essential to any great care that we give to our residents. And even though at this point this is specific to skilled nursing and rehabilitation, I teach trauma-informed care to the individuals who work with my assisted living residents as well as the individuals who are in our special memory care programs at Lifespace. So something for all of you to think about. Also with depression, we talk about depression in independent living communities, but depression occurs among every age group, in every social strata. Certainly, if you are in a CCRC, we see this among individuals in our independent living communities, as well as the assisted living communities, the memory care programs, as well as your health centers. But untreated depression often results in a resident who gradually does become a risk to himself or others. And sadly, someone who has untreated depression, who is socially isolating, feels absolutely no compelling reason to live, can often become suicidal. And those are all clues that we need to be watching for. But these individuals also expend a lot of staff time and energy, and sometimes we do need to facilitate an involuntary discharge or an eviction. But if we can recognize those subtle signs and symptoms of depression early, and we can link them up with, perhaps you've got a fantastic social worker in your community. Many of you do have geriatric psychologists or psychiatrists coming in. There are now more nursing master's degrees programs who are creating specialties in mental health nursing, and those nurse practitioners are able to come in. Fortunately, one of the advents of technology is telemedicine, and there are now telemedicine programs that are being utilized for counseling services, and that can be really fantastic for an older adult who still has that stigma about going to see the psychiatrist, yet our residents are becoming very, very computer savvy, and it's much more palatable and comfortable for them to have a one-on-one private counseling session on their computer via telemedicine with a geriatric psychologist or psychiatrist. So those are some things that we need to start thinking about. In assisted living communities, it's very much the same. Too many times we wait until someone is already expressing suicidal ideations before we have them evaluated and treated. And I am telling you, I have seen so many older adults whom once they received appropriate care and treatment and they were put on the appropriate antidepressants, continued to live very, very engaged, high-quality lives. So early recognition is very much the forefront of what we need to do as caring teams. Once that self-shunning and isolation occurs and the changing in self-care occurs that I spoke about earlier, if someone no longer cares about bathing and grooming and dressing and brushing their teeth, you're going to need many, many more boots on the ground to get that individual the care and services that they need. And sadly, in many instances, that may be too late. So very important that we think about depression among elderly adults. Okay, a little bit about relocation stress syndrome. I'm always very dismayed because over the past 5 or 6 years, we have all focused on reducing unnecessary hospitalizations and preventing hospital readmission rates from going over the national standards. That's something clearly we've done very well with over the last 5 years. But sadly, we really don't talk about the human element and what happens to our patients and residents psychologically when there's that constant boomerang between levels of care, particularly if it's the trajectory from the acute care hospital to a post-acute healthcare center, and then they're sent back to assisted living. And then guess what? They start decompensating, and within a week, they're sent right back to the emergency room. This is physiologically and psychologically very traumatic for our older adults, and it's something that we need to think about in addition to thinking about the reimbursement penalties for hospital readmissions and simply focusing on our hospital readmission rates. There is absolutely a human cost to these boomerangs of transition. So every community should be focusing on transitions of care. Certainly, there have been many, many studies, including studies that report multiple negative health effects once they're transferred from the hospital back to the long-term care community, including increased fall risks and certainly the risk of hospital readmission within their first week of being back. So we really, really need to make sure that we are looking at the human element of bouncing these people back and forth between hospitals. And at the end of the program, I was going to talk to you about a wonderful new resident at risk program we've put in place at Lifespace. And this is not for our health center or our assisted living residents. We already have very solid transition of care programs in place there, but we've actually started one in our independent living homes and apartments. And the interdisciplinary team gathers on a weekly basis, and they conduct a weekly resident at-risk conference. And it's not just the director of nursing and the executive director. We have the lifestyle directors. We have folks from culinary, from housekeeping, maintenance, the individuals who really engage on a daily basis with the residents who are living in independent living, many of whom may not be coming out of their apartments for every meal. But we try very, very hard to identify, and again, this is early recognition in any of those subtle changes of condition that may be physical, or they may be physiologic. If someone's congestive heart failure is getting much worse and they're having a great deal of difficulty breathing, but certainly any cognitive or mental health changes that the team members are seeing. We try to identify them as quickly as possible so that, again, we can get care and services in place to intervene during those early stages before we end up having a psychiatric crisis or sending someone unnecessarily with the police to a local health department. And Kimi is going to talk about some other really wonderful risk management programs that are in place.
Thanks, Sara. So quickly, just to go over a couple aspects of suicide that are unique to long-term care that I think are usually pretty surprising is that, 75% of older adults who die by suicide have never made a prior suicide attempt. So that means that the risk factors for suicide that we think of when we look at someone who's younger, someone in their 20s or 30s, we say, okay, is this person giving away their possessions? Does this person seem to be withdrawing from physical activities? Has this person previously talked about suicide? Those aren't really going to be that helpful with older populations because so much of getting older, especially when someone is nearing end of life, is actually about the saying goodbye, getting your affairs in order, setting your will up. So those normal behaviors that we associate with suicide are actually a typical process for your residents. So residents are really going to have to struggle with, how do I see myself aging, myself changing, my role in my family, and thinking about the future when I may not be present, with also still wanting to enjoy life. And so you don't want to miss signs of suicide, but you also don't want to say, okay, well, this person just made their will, so maybe that means they're at risk. Instead, what we really look at is how they view senior living. And I think that the way a resident views their new home in the community is a really good predictor for whether they're going to be at risk for depression and then whether that would roll over into suicide. And it goes very well with what we like, in senior living now, where we think of it as a community, as a culture. Residents who were in the silent generation, which is kind of the generation right before the baby boomers, and the greatest generation, they were the Depression era generation. They saw their family members go into nursing homes as a place where you go to die. And unfortunately, many seniors do still view going into a home, going into that nursing home as the end stop. And so I think one way that you can even do this, even in your marketing materials, is to phrase it as a community and phrase it as a next step. It's a move to a new neighborhood almost. It's not a nursing home. And I think that is something that will change how your residents perceive their role, and it will also change how your staff perceives it. And if your staff perceive the residents as active adults, as active, not necessarily physically active, but as real individuals and see them as individuals, they're not going to necessarily view them as just a number on a chart. They're overworked, they're stressed, and they may not be able to interact with each resident if they don't view it as a community atmosphere. And the other aspect of suicide that's very hard from an employment perspective is it does increase staff turnover, because it is incredibly traumatic when you have a resident take their own life, and unfortunately that usually is going to be followed by an investigation by the police, angry family members wanting to file a complaint with the state, just because it's a catastrophic event, and it also can unfortunately lead to additional residents attempting to or taking their own lives. So the takeaways for preventing suicide and depression are really trying to change the cultural feel of your community. But right along with that, we turn right into bullying in senior living. And you'll notice, all right, we'll be up in a second, the slide that has the image from Mean Girls on it. And I don't know how many of you are familiar with Mean Girls, the movie, but it came out several years ago, and it was really about the queen bee culture within high schools. And everybody I know, you can take 2 seconds and think back to what it was like to be in high school and the lunchroom dynamics. And I have to tell you that one of the most common issues that I see in working with senior housing providers is this feels just like high school. How do we deal with the resident-on-resident bad behavior that's occurring? And unfortunately, between 10 and 20% of all senior residents are mistreated by their peers. It very much is like creating a dorm or a high school setting. We are throwing a group of people together that wouldn't necessarily have chosen to live together. They're having the same meal, 3 meals a day, with the same people every day for potentially the rest of their lives. And unfortunately, hierarchies develop, and it really does sometimes bring out the worst in people. Many times bullying often is associated with power and control. Residents are feeling like they've lost control over their own lives. They're now living in this community, and so they're going to exercise it in some way on others. There's also a seniority system where older residents are rude to younger residents and expect preferential and deferential treatment. No, you can't sit at this table. This is the table that we always sit at. No, I don't think you get to join our knitting circle. You just moved here. And I think that can be very, very detrimental. When you have a status-based form of bullying, I think that is especially dangerous because that can actually open up your community to issues with the Fair Housing Act, issues of discrimination, and even if it's not coming from your staff, that can certainly trigger an investigation by a regulatory agency. So when I consider status-based, I think of anything related to their clothing, their social status, their economic background, even down to their apartment size and unit. This person walks around wearing Chanel and has the largest corner apartment. This other resident got in there because you also have to take residents who are on Medicaid. That can lead to a lot of nastiness. And I think the number one thing we hear from residents is, I'm old enough, I don't have to pretend to like people that I don't want to like. And that creates a very, very negative atmosphere in your community and can lead to the other types of mental health issues that we were talking about. So I think a lot of times we're afraid to act when we see that type of bullying going on. As a community manager, as a nursing director, you don't want to overstep. You certainly don't want to touch on anything that might actually be related to someone's status in a protected class. But the best way to handle that is really to step forward and call out the behavior in a professional way, whether that is having a policy that prohibits saving seating, whether it's pulling aside a resident on a one-on-one basis. Or another thing that's kind of a more creative and underhanded response actually is to invite certain residents that you know are problematic to a kind of resident safety task force meeting. Invite in a member of the local PD as a guest speaker and have them talk about the harm of verbal assault. And then in a couple weeks, you can actually follow back if another incident occurs and say, well, this actually makes us think. We know you attended the meeting, and as a member of our safety task force, obviously you would know that this would constitute assault, and call the behavior out that way in such a way that you're still respecting someone's autonomy as an adult, but also saying, just like you were in the workplace, you have to adhere to certain standards of behavior. And that's not just to protect your residents, but that's also to protect your staff, especially when the abusive behavior is directed at staff. It's not uncommon for residents to actually engage in racist comments or sexist comments or sexual harassment with your staff members. And your staff, protecting your staff has to be a key priority, and that begins with having a no-tolerance policy on that type of behavior, educating residents, having reminders and posters up about bullying and the harm that it causes the culture of your community.
And Kimi, if I could just add, in a few situations in the past where the bullying has truly become abusive, I've actually utilized a civility consultant. And be aware that there are psychologists who are available who literally specialized in civility consulting and counseling for older adults. And if this is prevalent in one of your campuses, in addition to your executive director, your administrator, your team members having zero tolerance for this form of abuse and neglect, at times you really do need to bring in outside individuals to have individual and small group trainings to explain how these behaviors really have a deleterious effect on the lives of everyone living in the community. It's very difficult to deal with bullies. So I appreciate you talking about that.
Agree with that. I think that can also help you if you do end up with a regulatory investigation, saying, what steps are you taking to try and prevent these problems that are happening? We've received these complaints. You can say, we have done X, Y, and Z. The other thing I want to mention that's becoming more common is actually cyberbullying in the senior population. So seniors with almost everyone has a smartphone now, taking mean pictures of other residents, texting about other residents, sharing information. And then we all know the problem with employees actually texting or taking pictures of residents. But I just wanted to bring that to your attention that it's happening on a resident-to-resident basis as well. And from a data security perspective, it's really important to educate your residents on how to protect their accounts and protect their pictures, and that they need to really keep in mind that what they're posting actually is permanent in the same way you would if you had a junior high student just starting to kind of have full use of a smartphone. And I know Sara is going to talk a bit about substance abuse, which unfortunately can result from depression and bullying and the other issues we've discussed.
Absolutely. I don't know if anyone on the line, you've likely known someone who has very serious depression, and many times they begin medicating themselves to escape from the pain, whether that's excessive alcohol use or recreational drugs. Now, of course, in the United States, we're facing a major opioid crisis that is not only impacting young adults, but certainly we have many aging adults who are severely addicted to multiple different types of opioids. And I know we see this when we admit residents to our health centers. I mean, I'm amazed when I look at some of the medication administration records, how many different pain pills these individuals are on. Or older adults may doctor shop and try going to multiple different specialists to get refills on their Tylenol number 3 or their OxyContin. So this is another subject where all of your interdisciplinary team members really need to work together to evaluate and assess residents to make sure that we don't have significant issues of substance abuse, whether that's alcohol or drugs. Certainly, we are in the process now of opening some of our new redevelopments, and even in our health centers and assisted living communities, we've built really, really beautiful pubs. And I can't tell you how much our residents love having their Friday night cocktail hour. and they sit together and they have cocktails and appetizers. We should not be judgmental about individuals who have had responsible drinking habits throughout their lives. I have worked with some individuals who have basically said, well, we call the physician and get a no alcohol order for anyone who's admitted to our health center. And that's not really our right at all. And Kimi may say a few more things about that in a moment. But where you have residents who are clearly unsafe with their drinking behaviors, whether that is binge drinking or you know that they are incredibly intoxicated, they're having more falls, perhaps they're starting to berate their neighbors or they're getting more aggressive once they've been drinking, those are certainly things that we need to intervene and make sure we safeguard the resident and everyone else in the community. Certainly the rates of alcoholism are again highest among Caucasian aging adults, which is very similar to suicide. And many aging adults do not even realize that they've developed an alcohol problem due to isolation or self-imposed seclusion. In addition to pain and discomfort and using alcohol to treat pain, individuals absolutely use alcohol to treat their depression and their feelings of isolation and loneliness. So that's always something we should be assessing for. And polypharmacy, the last thing I'm going to say, Kimi, before I have you speak a little bit about alcohol, polypharmacy is an absolute crisis in senior living and post-acute care. When we receive residents from the hospital and they've got 25 routine meds and 10 PRNs, you can be guaranteed there is going to be a very, very significant drug reaction. So I would hope that every provider on the call today is doing a pre or post-admission review of all of the prescription drugs as well as the non-prescription drugs and supplements, because they can have a very, very deleterious and serious effect on someone's mental health as well as their physical well-being. Many times it's these individuals who have significant issues with polypharmacy who are frequent fallers. Perhaps they're very depressed and getting very confused. So we should always be doing very, very thorough medication assessments, starting slow, going low with drugs, and eliminating any unnecessary drugs that resident may not need for their treatment and care. So Kimi, anything else about alcohol?
Yeah, I would kind of from a legal perspective, I would definitely say that having a blanket no alcohol policy, especially when you have a resident who is mentally competent, would be a significant violation of their rights. We have to remember that residents have complete and full autonomy, and the capacity to make certain decisions about their health care may not be the same capacity that they have to manage their finances. So just because, say, someone has a financial power of attorney in place with their adult child doesn't mean that adult child can control every other aspect of the resident's life. So I think, having and respecting that individual boundary, unless you think there's a problem, is also really important. Kind of moving on to our next section is really, how do residents access mental health care? I know, unfortunately, one of the issues we have is we always ask, okay, but who's going to pay for this? And I think it's really important to kind of realize that, unfortunately, it's really not Medicare. When I first learned that Medicare Part B actually does not pay for licensed counselors, that was shocking to me, because those are the two most common types of mental health practitioners. They're more readily accessible. It doesn't take as long to get an appointment, and their rates are often much lower. So right away we have residents who, if they're only relying on Medicare for their health care funding and coverage, are not actually going to have access to licensed counselors to deal with their issues. And Part B does cover an annual depression screening, but the screening has unfortunately been found to be ineffective. It's especially ineffective when you have populations that are from minority communities or communities that have traditionally not trusted kind of physicians or persons that they may see as having authority. Even the screening is found to be effective with the introvert population, where somebody is not actually going to share their feelings with a stranger or their physician, where they feel like they actually want to show that they're competent and they look really, really good and they're doing well, whereas what the provider doesn't actually know is that getting up, getting dressed for this appointment is the first time they've left their house in a month. So you have a real problem with how do we get access to care for your residents when it's not coming with the care type of insurance that they're all on. So I've been following this pretty closely, and unfortunately it really has not had a lot of forward movement, but it was a Mental Health Access Improvement Act that was actually going to try and allow the coverage of marriage and family therapy and counselor services under Part B. It's actually still sitting in committee, and I'm continually hopeful that it might come through. But I think at this point we have to really turn to other types of practitioners and think, do you have a geriatric psychiatrist, not necessarily on staff, but on call? And do you have a psychologist or mental health nurse practitioner available to support your residents who either require psychological counseling or just routine mental health care and checks? And I would encourage everybody to really implement a mental health risk management plan. And we titled our presentation, Mental Health is the New Fall Risk, because I really believe that, and Sara and I both really believe that that is the level of importance that mental health is. When the idea of preventing falls and fall risks kind of took hold several years ago, it was basically spurned on because of the extra costs associated with falls. If a patient falls, their life expectancy can actually shorten. It costs extra money for the community. It costs extra supervision, extra care. They may be admitted to a SNF. They may have readmission. It may cause transfer trauma. So we put into place call protocols that everyone at every level of the community had to buy in. And I think that putting in preventative mental health care in the same type of rigorous approach is actually going to lower costs for communities in the long term, and that's what we'd encourage you to do. So the first step in that would be leading just an overall effort to raise awareness on mental health. And the most important thing is to involve all levels of staff. So I like to say this needs to be from your custodial team all the way up to your C-suite. Everyone needs to be involved and engaged in resident mental health. And I think it's especially important for the custodial team, the everyday team, your housekeeping team, the teams that see your residents every day. Because while a C-suite person may get a report saying, we actually had a suicide over in our, Sun Valley building, the custodian in housekeeping is actually going to say, yeah, Mrs. X, she hasn't actually gotten out of bed in weeks. She doesn't want to go to the dining room. The chef might notice she's not really eating her meals. So I would encourage everybody to be empowered to actually say something, when you see something, to say something. It truly matters in mental health. And I think to the extent that privacy laws allow, they should provide mental health updates to residents and families if the patient consents. If the patient has authorized a family member to receive healthcare updates for them, then I think that family member does need to be looped in. And really, just as you would in a fall prevention space, create programs and policies and procedures that include a budget allocation for enrichment programs that serve as a type of proven mental health therapy, whether that's pet therapy, art therapy, acupuncture, Tai Chi, and really also target those bullying concerns.
Kimi, can I just add one thing? I am such a passionate advocate for quality life enrichment programming, and I would really ask everyone on this call to please go back to your community and critically appraise your life enrichment calendars for every level of living or every level of care. And if you see birthday Bible and bingo, you do not have a meaningful life enrichment program. It is absolutely critical that we have dynamic life enrichment leads who have the education and training to impact meaningful programming. And at Lifespace, we belong to the Masterpiece Living program, where we are developing centers of successful aging, and we require, in addition to the number of life enrichment programs that must occur every day in every type of a program, that each of them include social, intellectual, physical, and spiritual life enrichment activities that are tailored to the residents' wants and needs. And that's also part of doing that very in-depth social history and getting to know your residents, because residents who are out of those apartments, they're socially connected, they're engaged, they are not the individuals who are going to be lying in a fetal position alone in their apartments with profound depression and suicidality. So it's really important that everyone critically evaluate their life enrichment programs.
No, thank you, Sara, and I could not agree more with that. And that's kind of part of establishing an interdisciplinary mental health prevention and response team. The prevention team is going to be made up of your social workers, your event planners, your risk management, and the response team would be activated whenever you have a resident that's actually showing signs of mental health challenges. And then try and use a real tool to say, okay, this person is ticking several boxes here for depression, and noting that. Next, I would say develop an individualized plan of care, and that's that individual assessment that Sara was just talking about. And this can be really simple for a resident that is actually very independent. Make sure that they're still coming to things. Make sure that they're participating, and respecting resident autonomy is key. And then having proven interventions. And you can see there Sara's birthday Bible and bingo. I mean, if that is all you have, that's terrible. It's a great first step, but it's definitely not going to be an adequate way to help fulfill your residents' lives. And I think that using a third-party counseling service or telehealth counseling is a really new and interesting way to provide resources to your patients. The privacy lawyer in me would definitely say, okay, you need to think, what type of community are you? Are you a HIPAA-covered entity? Even if you're not, you're now going to potentially be transmitting health information, so you need to have those processes and protections in place. I would say, you always need to have two-factor authentication on your account, especially if they're using your kind of portals to conduct the counseling. But those are all things that a privacy specialist can absolutely advise you on. Those should not be hurdles where you're like, oh, we don't want to take on that risk, especially when it's a great thing to offer. And you can actually offer it just like you do any other amenities. I know plenty of independent living communities that say that we offer free hearing tests and hearing aid adjustments. Well, on Thursdays, we offer free telehealth counseling if you want to just talk to somebody, and you can sign up for this online slot and nobody even needs to know. I think that's a great way to use technology. And finally, when you do have an incident, whether it's a suicide, whether you have an attempted suicide, or somebody that was transferred out because their depression or substance abuse got so bad that they were not safe to live in the environment anymore, you need to do a post-incident huddle, and that should include everyone on your task force. It should also include the legal department. Unfortunately, in some cases, that's going to include a pre-litigation assessment. That doesn't mean you're going to get sued. It just means you're getting your ducks in a row. And I think the advice I always give my clients is never be afraid to call your lawyer. Not just that we're actually very nice people, but we can help issue spot. We can help say, okay, let's shore up this. Let's make sure we've got the right documentation and understanding of what happened to really respond effectively.
I would agree with that, Kimi, and I will tell you that over the past 40 years, sadly, I've had to deal with multiple suicides in senior living communities and health centers, assisted living. Some of them were even double. They were murder-suicides. A husband, had been caring for his wife with Alzheimer's disease at home for years. She moved into a secured Alzheimer's dementia program. He would come every night to visit her at supper, and one night the nursing assistants went in to put her to bed, and he had cut off her WanderGuard bracelet. It was sitting on the bedside table. He had quietly taken her out of the community and checked them both into a Comfort Inn about a mile from this particular community. And he shot his wife and shot himself. And I've gone through that several times. So whether these suicides occur inside your community or outside, it's extremely traumatic for the residents involved, the families involved, but certainly all of your team members. So this last point is very important. I think everyone on the line has an employee assistance program with a private line that can be called. When this type of an incident happens in one of the communities I've worked with in the past, I will always bring in a chaplain, or I will bring in a counselor who can do individual or small group sessions for any team members who want to talk about their feelings. But it is very, very important we allow our team members to process these critical events because they are very traumatic and lasting. So thank you for mentioning that, Kimi.
Yeah, and I would add from a legal risk perspective, by having the appropriate emotional support in place, that actually is going to reduce the likelihood that you might have an incident where an employee feels like they have no outlet but Instagram or Facebook to vent about the terrible thing that happened at work. If they're actually given the tools to process that information, it's less likely that they're going to go ahead and post a blog to kind of relieve that stress, which may ultimately end up with a notifiable incident that might make the media. So I could not impress upon each of you the importance of doing those post-incident huddles. And we know we've thrown a lot at you. If anyone has any questions, we are happy to answer them the best we can.
The other thing that I will say, because I know we have limited time this afternoon, we have our personal and our work email addresses here in front of you. Please feel free to use these email addresses if you would like to email Kimi and I any questions. We'd be more than happy to respond to you. If anyone would like a policy on the weekly at-risk meetings that we hold in my communities to review residents, I'd certainly be more than willing to share that. So we will open up the line for questions, Robin, but if not, you can certainly contact us personally.
Do you have any recommendations for additional resources?
Absolutely. I think certainly for those of you who have individuals with Alzheimer's disease and other dementias, your local Alzheimer's disease chapters are incredible. But honestly, if you Google or you have access to the academic search engines, you can put in depression and aging or schizophrenia or hoarding and just get, hundreds and hundreds of articles. So I use Google quite a bit when I'm trying to find additional resources. And then certainly the mental health associations have not only pamphlets and brochures, articles, books that they are willing to give you or to borrow. Many times they have speakers who will actually be willing to come into your communities to give some of these lectures to educate your team members and residents.
And I would add, when you're looking for resources, really try and look for those that are specifically tailored for seniors, because unfortunately a lot of the resources out there on depression and suicide are actually going to have the signs and symptoms that don't appear in seniors. It always surprised me when you read that sadness and crying is not necessarily a sign of depression in the elderly. So I think it's important to have those tailored resources. And if anybody is interested in resources from the privacy side or the clinical side, I know Sara and I can provide those to you.
Well, and I'll give you another personal example, and this isn't with geriatric adults, but I have 2 certified golden retriever therapy dogs, and they both went to Marjorie Stoneman Douglas High School after the tragic shooting last year, and they worked with the kids and the teachers for several months, as well as the entire Canine Assistance Therapy organization. And most of those handlers and trainers are in their 60s, 70s, and 80s. And it became very, very clear to many of us that many of them were experiencing post-traumatic stress syndrome, listening to all of these terrible stories. And even in my husband, who is my dog's handler, he would get very quiet just as he processed some of the stories he heard. And we were able to reach out to an academic institution in the Fort Lauderdale area, and they actually sent some of their PhD students in counseling to meet with and educate these team members about how what they were feeling was absolutely normal and that they're going to work through a natural grieving process. So I think your academic colleges and universities are also just a wealth of opportunity and resource for your communities for education and training and getting some of those students into your communities.
That's a great idea. Do you have a recommendation of a telehealth provider group?
I do not. There are many available on the market. Many of the telehealth providers are using more of the physiologic monitoring with blood pressure, pulse, respiration. But if you do Google mental health telemedicine, I'm sure that there will be providers that will. Because my communities are in large metro areas, we're very fortunate. We have psychiatrists and psychologists who are coming into our communities regularly, as well as mental health nurse practitioners. But I know it's very difficult in some of the rural areas.
Sure. And what about for the bullying interventions? You mentioned posters and other resources. Is there a place to get those are already created?
Yes, and actually, if you go on YouTube, there are some really wonderful educational videos on bullying and lateral violence, particularly for nurses. I do quite a bit of writing and speaking about lateral violence and bullying among nurses, and there are some great resources on YouTube.
Excellent.
Well, thank you so much to everyone for participating today. And again, this was a very high-level, quick overview. I'm sorry we couldn't get into a lot more detail about each of the topics, but I think it's such an interesting topic for all of us, and one, again, that we want to make sure our team members are educated so we can provide the best possible care, not only the physical care, but the mental health and mental wellness aspect of what we do as providers every day.
Absolutely. Yes, thank you so much.
You're welcome.
Sara and to Kimi. And now for anyone who's interested in learning more about Direct Supply's role in assisted living, please join me in welcoming our clinical director, Liz Jensen.
Thanks, Robin. Hi, everyone. I'm Liz Jensen. I'm the clinical director here at Direct Supply. I just wanted to take a few minutes just to thank Sara and Kimi for joining us today. We've never covered a topic like this before. This was new for us. And I think that it's a topic that's a weighty one. It's one that I think that is incredibly important and touches all of us in one way or another. Having been a nurse and a former nursing executive and educator for providers in our space, I can tell you that I've too have had some of those similar stories, which no one wants to have to think about or recount. I wanted just to share a little bit about Direct Supply and some of the things that I have found as being the clinical director here that I think a lot of providers may not be fully aware of some of the things that we can help with. Many of you are probably familiar with your account manager. You're probably familiar with either the person that you talk to if you contact and speak with someone from Direct Supply frequently. But I think what you would find as you go a little bit deeper is we have a number of people that come and visit our campus. I think last year we hosted over 500 customers that came to our campus and visited. And what we do when people come here to campus is really try to create opportunities for people to learn together. We've hosted teams together here before, teams made up of nurses, physicians, social workers, therapists, some maintenance directors, administrators, lots of different people from the healthcare team and the clinical team that come here for lots of different projects that they might be working on. But what we find is that it's a real opportunity for them to engage in some different kind of dialogue. We can talk about how to create spaces that might encourage better person-centered care. We can talk about and help you think through some of the challenging things that you might be faced with, such as an older community where you're not quite sure what you can do to create environments that, people feel really that is their home and that they feel comfortable with. So I would encourage you, if you've not thought about coming here before to visit our campus in Milwaukee, to think about it. We will have a great time, and we'll introduce you to some great people. You'll get an opportunity to see a lot of the new things that we're working on here as well. So if you're interested, please reach out to your account manager, and thank you for joining our webinar today.
Thank you so much, Liz. And thank you again to Sara and Kimi for your time today. For more information about upcoming webinars, please visit directsupply.com/webinars. Once again, thank you for attending today.